Hello, my name is Asma Mohammed, and today I'll be presenting on electrocorticography. To start off, what is electrocorticography? Electrocorticography, or ECoG, is a type of electrophysiological monitoring conducted to record brain activity. If you've heard of electroencephalography, or EEG, you may have noticed that it's a bit similar. Although ECoG is used for a similar purpose as EEG, the main difference is that ECoG directly records from under the skull, while EEG is non-invasive and done from over the skull. This makes ECoG fall under the umbrella term intracranial EEG. As mentioned, ECoG is done from under the skull, which means that there is a surgical procedure involved for the placement of electrodes. The advantage of ECoG, as compared to EEG, is that ECoG is able to record directly off the cortex. EEG records off the skull, which is hindered by the many layers of skin and skull in between the electrodes and the activity. So obviously, ECoG, which is directly recording off the surface of the brain, is able to relay data with high spatial and temporal resolution. It is important to note, however, that ECoG is not as helpful with recording from deep parts of the brain. Chronologically, ECoG would be done as a later resort due to the surgical implications of the procedure, so it's usually preceded with EEG or MRI. ECoG was started by Wilder Penfield and Herbert Jasper in the early 1950s. It was developed as part of the Montreal procedure, which was a novel surgical protocol that could treat patients with severe epilepsy by identifying the regions of the cortex that were generating epileptic seizures. ECoG helped identify these epileptogenic zones by recording cortical potentials. So how does ECoG work? Electrodes or grids of electrodes are placed either under the skull, known as epidural ECoG, or further under the dura mater, known as subdural ECoG. As I mentioned, ECoG is directly on the cortex with only thin layers of pia mater or dura mater in between. So it's completely under the skull on top of the brain. To place these electrodes on the surface of the brain, first the skull is surgically opened by removing a part and exposing the brain. This can be done under different types of anesthesia depending on how much patient interaction is needed. After the brain is exposed, the electrodes are surgically placed on the cortex with previous data from preoperative EEG and MRI. As I mentioned, this placement can be either epidural or subdural. ECoG recording uses electrodes or grids to record cortical activity. ECoG grids are small electrodes that are placed either under the skull for epidural ECoG or under the dura mater for subdural ECoG. There are different arrays of electrodes that can be arranged, such as 1x4, 1x6, or 1x8, but these are all linear strips. There are also grid arrays such as 2x4, which help in covering more surface area and are therefore also used for ECoG. Direct electrical cortical stimulation parameters are important for helping the ECoG be as clear and helpful as possible. The Oshman cortical stimulator is used to deliver electrical stimulation to the cortex, the response of which is recorded by ECoG. The stimulator delivers biphasic pulses, positive and negative phases, to reduce the risk of tissue damage. Surgeons typically apply brief pulses, such as 50 Hz for 2 to 5 seconds, while asking the patient to perform tasks like speaking, counting, or moving. If the stimulation temporarily disrupts the patient's ability to perform the task, that area is marked as functionally important. There are two ways that ECoG can be used. The first is extraoperative ECoG, in which electrodes are left implanted on the brain for days to weeks to help monitor brain activity over time. This is useful for the original purpose of finding epileptogenic zones. The second is intraoperative ECoG, which is performed during surgery to help in identifying important structures, which would help in preventing damage. Cortical excitability refers to how easily the neurons in the cortex can be triggered. In terms of ECoG, it is important to keep an eye on cortical excitability to prevent the accidental triggering of a seizure. So, to prevent unwanted seizures, we try to control cortical excitability. There are a few ways to do this. One way is to decrease stimulation intensity, or level basically. Sometimes it will be a complete pause of stimuli to allow the seizures to stop and to return to baseline. Another way is to decrease stimulation epochs. This is the time of the stimulation, so basically apply the stimuli for less time. A third way to control cortical excitability is to irrigate the cortex. This helps with cooling down the triggered brain regions. Thank you for listening.